Hello, everyone. Welcome to another Management Reasoning virtual morning report. So happy to see you all on this Saturday. I hope you are having a good day. I hope the weather is good wherever you are. We have a great case to discuss today with Noah. Noah, do you want to say hi to everyone?
Hey everyone, we have cases to discuss today. It's going to be a little different and we really want everyone to participate. We're going to do breakout rooms, so feel free to open your camera, introduce yourselves in the breakout rooms. And yeah, it's going to be great.
Yeah. Aisha volunteered to describe and help us with those cases today. And we have 4 cases. You will see once we share the screen, there are 4 different cases and we're going to do breakout rooms. What we want of you in the breakout rooms is to discuss these cases and we'll ask you a couple of questions. So I'll be assigning them right now. And Aisha, if you can share the screen, that would be wonderful.
Can you make me host, please?
Yeah. So these are the 4 cases that we have for today. The case 1 is a 70-year-old male presenting from a nursing home for altered mental status for 2 days. The urinalysis was positive for 20 white blood cells and a positive leukocyte esterase. Case 2 is a 65-year-old male with recently diagnosed prostate cancer presenting for a routine clinic visit. He is scheduled for a procedure next week, and he was found to have a urinalysis that's positive for a leukocyte esterase and a white blood cell count. Case 3 is a 65-year-old woman coming into clinic for 2 days of malodorous urine, and the urinalysis is positive as well. And lastly, the case 4 is a 24-year-old female, gravida 1, para 0, presenting at 16 weeks for a routine clinic visit, and the UA was positive for leukocyte esterase and white blood cells. The questions we want you to tackle in the breakout rooms are, how do you diagnose a UTI? What are the signs of symptoms of UTI? And so in this case, is this a UTI? What workup do you want? And what treatments do you want to deliver to this patient? In general, like your thoughts. We would want you to all discuss all 4 of the cases, but we will ask you to just discuss one afterwards. So I'm going to create the breakout rooms now. Welcome back. I saw that discussions were extremely lively in all of the breakout rooms, which seems amazing. I really look forward to your answers. My first question is to breakout room 1. I don't know if you chose a representative to tell us what you discussed about the first case. That would be Alex, Austin, Nora, and Ella, the group.
I don't think we formally picked anybody, but I'm happy to chat. So our group for the first case, we were thinking that we were kind of going through the several questions that you've listed on the all the way on the right hand side on the teaching points. So in terms of whether or not this was a UTI, we felt like we probably needed a little bit more information. So the hard to elicit symptoms of dysuria, urinary frequency in this gentleman who's coming in with altered mental status from a nursing home. So we felt that maybe our first steps would be to look for any going through the missed mnemonic and looking for other reasons why this patient might have an acute change in mental status. And if we were able to, it's challenging, and given the severity of the clinical situation, we recognize that in most cases a patient like this does end up on an empiric antibiotic therapy. But if we were to evaluate this patient newly, we would think that maybe if we could find another reason for this patient's altered mental status, we might hold off on antibiotics, leading away from a diagnosis of a UTI. And then in terms of other questions that we talked about, so we talked about kind of if we did think it were a UTI, how would we treat it? So we were deciding, like, would it be a complicated UTI versus would it be an uncomplicated UTI? And we said that altered mental status doesn't necessarily indicate a complicated UTI. So that might dictate that we would choose a shorter antibiotic duration, like 3 to 5 days as opposed to 7 days. But with that said, given that this is a gentleman coming from a nursing home, we'd want to know other if the patient had recent hospitalization, or we'd want to know a little bit more about this patient's vital signs. If he did have clinical sepsis, for example, we might jump to choosing a broader agent that would provide pseudomodal coverage. So I think bottom line was we felt like we needed a little bit more information, but we had a very, very good, rich discussion. But anybody else, feel free to jump into.
Thank you, Alex. It sounds like a very rich discussion. We will touch on this shortly, but it sounds like an excellent discussion. Anybody from group 2 want to talk about the case you talked about? That would be the group with Ariel, Maddie, Marino, Yaz, Abi.
Yes, we have a gentleman, 65 years old, with recently diagnosed prostate cancer, and during a routine visit prior to his scheduled intervention, the TURB, he was found to have a urinalysis for leukocyte esterase and high white blood cell count. Now, this, in my opinion, points very strongly towards a UTI secondary to obstruction caused by his enlarged prostate, secondary to his cancer. So we can at least say there is some kind of pyuria. We don't have any vitals where we can see probably fever or other signs. That would be, if it turns out to be a UTI and the esterase and the WBC strongly indicated, would be a more complicated UTI. It requires treatment. It would even require treatment with, I think, ciprofloxacin if he had no signs of UTI, just to make sure that his procedure does not cause secondary infections. So here we would have obstruction of the urethra as a possible cause from prostate cancer.
Thank you, Hans. I joined your group intermittently. Marino, do you want to go next, or someone from your group?
I mean, I can jump in if no one else wants. Okay, so this case of a 65-year-old woman that comes for 2 days of malodorous urine, and her U is positive basically for an UTI with leukocyte esterase and white blood cells of 15. We were kind of talking about, like, is really her malodorous urine like the only sign and symptom that she will get for an UTI? So we were discussing that she doesn't have a classic presentation of an UTI. She doesn't have any frequency, burning, dysuria, nocturia, hematuria, or suprapubic tenderness. So we started to also consider other risk factors that she may present, and that's her age. She's on menopause, so maybe we were talking about the possibility of a genitourinary syndrome of menopause that could predispose her to get infections over there. And also, like, talking about, like, is really her urine what is malodorous, or some sort of secretions near the area that can contaminate the urine and make it malodorous? So that's one question that jumped right away to us. And we were thinking about, like, to know if this is really a UTI, we evaluated the possibility of taking an urine culture for her, because she has pyuria, but we don't know if it's sterile or is really, or if she really has an UTI. So we kind of had to hold treatment for her. We don't know if she really needs a treatment, but maybe we can, like, take her urine culture and proceed, like, with empiric treatment for a uncomplicated UTI, like amoxicillin or Solfast, like going that way.
Yeah, thank you, Marino. Then we have one more group. I don't know if we have a representative from that group.
Hey guys, can you guys hear me?
Yes.
So we have case 4, so 25-year-old female G1P0 at 16 weeks for a clinic visit, and has a UA with leukocyte esterates and white blood cells greater than 15. So for this patient, can't formally diagnose a UTI right now. Definitely would like a urine culture for a few reasons. As kind of mentioned before, like, pyuria doesn't always mean, cystitis, right? Especially in a patient like this, you could have urethritis, you can have vaginitis, you can have other causes of pyuria, even like ureter causes like a colitis or an abscess that can all lead to pyuria. So the differential for pyuria is definitely really broad. But if we do have bacteriuria, this is a patient that even if they weren't having symptoms, I definitely would treat with antibiotics. Pregnant patients with asymptomatic bacteriuria are an increased rate of pyelo, adverse pregnancy outcomes. So that's definitely one population that we do treat with antibiotics without symptoms. And then, always keeping in mind that, looking at antibiotics that aren't teratogenic, right? And some antibiotics are teratogenic in the first trimester and maybe not in subsequent trimesters. So talking to your local friendly pharmacist or Lexicomp or UpToDate is definitely helpful here. But usually like a amoxicillin or a cephalosporin is usually safe here. And courses are kind of similar to like an uncomplicated cystitis. I think the data is not great for how long to treat asymptomatic bacteria in pregnant patients, but it's usually kind of similar to short courses for uncomplicated UTIs. But yeah, just making sure you elicit any of those symptoms for cystitis, urethritis, vaginitis, pyelonephritis is really important.
Thank you so much, Mark. Are you talking to us from work? Sorry, I don't mean to. I just noticed that you're like
Yes, I have I'm at the Philly VA right now, and we're on our 28-hour shift, and we just got our first patient. So I might step away from a sec, but we weren't too busy, so we figured we'd log on.
That's awesome. You have a bunch of really smart doctors here if you want to consult them.
Yes, I do.
Noah, back to you.
Okay, what an amazing discussion, everyone. And I'm really happy with the results of the breakout rooms. So well done to you all. Okay, so let's start with some definitions, because I think that's a way to clear up any confusions we may have. What is an UTI? An UTI is signs and symptoms that localize an infection to the urinary tract plus significant bacteriuria. In select patients with classical signs and symptoms, we don't have to get a urine culture to call it a UTI, okay? So UTI, signs and symptoms that localize an infection to the urinary tract. What are those signs and symptoms then? Dysuria, urinary frequency, urgency, and suprapubic pain. Hematuria can be observed in some cases, okay? The classic presentation that I think Marino mentioned is the presentation of UTI, okay? And what are not symptoms of UTI? AMS, changes in urine color, and urine smell. So if you have isolated AMS, that is not a symptom of UTI, even if you have a dirty UA, okay? So what about this dirty UA? So when we say dirty UA, we often mean a UA with pyuria, with leukocyte esterase, as we have in those cases, or maybe even a few bacteria. Isn't that indicative of an UTI? Again, an UTI is when you have signs and symptoms that localize an infection to the urinary tract. So it doesn't matter if you have pyuria, it doesn't matter if you have bacteriuria. If you don't have signs and symptoms like urgency, dysuria, pain, this is not an UTI, okay? So the first case, elderly gentleman with altered mental status and a pyuria, so dirty UA, one presentation, this is not an UTI. The group was spot on. You have to look for other reasons for the altered mental status. The second case, so we have a pre-op patient, it's gonna have a neurologic procedure, and he has pyuria in his UA. This patient, we don't have an UTI because he doesn't have symptoms, but we do have an indication to get an urine culture because he's going to have a procedure next week. So we have to make sure that his urine is sterile. So we would get an urine culture, and if he has bacteriuria, we would have an indication to treat that asymptomatic bacteriuria. So it's not an UTI, just bacteria in the urine. The third patient also doesn't have an UTI. She just has pyuria in her urine and some changes in urine odor. And you guys brought other possibilities for those changes. In the fourth patient, we have possibly asymptomatic bacteriuria in the pregnancy, and the fourth group was spot on. You have to get an urine culture and you have to treat it. in pregnant patients. Going back to the first case, we were saying that maybe the AMS could be caused by an uncomplicated UTI. So we even put in the treatment options, complicated versus uncomplicated. So what is that definition? What is complicated versus uncomplicated cystitis? You have to think anatomically. So you have the bladder and everything below. It's the lower urinary tract. So when you have an infection with those symptoms of the lower urinary tract, we have a simple cystitis. Anything else is complicated. So if you have any systemic signs like AMS and symptoms that localize to the urinary tract, then you can call it a complicated UTI. If you have fever, flank pain, costovertebral tenderness. Possibly, if you have AMS from a UTI, urosepsis, you'd get a septic patient with altered vitals and other systemic symptoms. So again, uncomplicated, simple cystitis, bladder and lower. Complicated, it's bladder and up and other systemic manifestations. And we have some classical teaching that men can't have simple cystitis, or immunosuppressed patients are always complicated, or patients that have, anatomical urologic abnormalities. Those patients can have a simple infection of their bladder. It's not because you are a man or you are immunosuppressed that you can't have it. Although those patients, they are at higher risk of progression from a simple cystitis to a complicated UTI. So those patients, you treat them for simple cystitis, but keep a very close eye to see the progression and the treatment response. Going back to the UA, when is it helpful? And I'm going to ask you again for your help. We're going to drop a poll in the chat. Yusuf, if you could.
I will do that momentarily. Let me add it now.
So we have a 36-year-old woman with dysuria and new onset urinary urgency. Would you get a UA in that case? And then we have a 36-year-old male with dysuria and new onset urgency. Would you get that? So the difference is between the gender. It's a woman with classical signs of UTI and a man with classical signs of UTI. When would you get an UA? Both patients, none of the patients?
The poll is active now. Yeah, if you can vote, it should be a pop-up screen on your screen. I don't know if it showed up or not. Under polls.
Okay, so I see we're kind of split in getting a UA for the woman, and we definitely want to get a UA for the man per the poll results. Can someone that wants to get a UA for the woman open up the mic and explain why?
So I can jump in. So I think for the woman, I would be thinking about the possibility of this being a cystitis. I guess the other thing I'm more wondering about is if the UTI, if the urinalysis doesn't show signs suggestive of UTI, like if it doesn't show leukosteries, if it doesn't show nitrates, I would be thinking about, could this alternative diagnoses like like chronic interstitial cystitis, I would want to take a little bit more of a history to get at diagnoses like that. But I guess I wouldn't be 1,000,000% convinced that this is only a UTI and just to jump to treat empirically. Although that could be reasonable in certain cases if we got more history.
That's a very great point. So a clean UA kind of rules out UTI in most cases. But this case is a woman, middle-aged, so probably like sexually active. She has classical signs and symptoms of UTI. So the probability of being an UTI is very high to begin with. Don't you agree? And then if you get an UA is a test like any other test. It's not 100% accurate. And maybe we get a false negative result. And if we do the pretest probability with the likelihood ratios of the UA, we would see that even after a negative UA, this woman still has a very high chance of having an UTI. So those patients, we should not get in UA. We should empirically treat, especially since it's a new onset of symptoms and there are not other features that suggest another etiology. While for the men, I agree with getting an UA because men, the prevalence of cystitis in men don't get UTI as often. So the pretest probability of having a simple cystitis is much lower. And getting an UA and seeing that's clean helps us rule out UTI. So that's when we get a UA for the patient, when we have uncertainty, when we have a probability of having a UTI, but it's not like very high, not very low. It's like kind of in the middle. So when we have diagnostic uncertainty, the UA can be very helpful to rule out a UTI. What about the culture? So David's asking, David's saying that in a middle-aged woman, the urine culture is mandatory only if recurrent cystitis. So urine culture, at least in my experience in the US, the hospital I rotated in, we would get UA with reflex. So every patient with a positive UA would get a urine culture. And we don't have indications for that. Urine culture is only indicated in select patients. So patients with a high risk of a multi-drug resistant organism, so we can get susceptibility testing, or high risk of progression of disease, so we can tailor the antibiotic choice. Even if you got UA in the first patient, the woman, we would not get urine culture. If the patient has recurrent cystitis, if it's very, the time interval is very short. So if I get a cystitis today, and then 2 weeks later, I get another cystitis, we're going to start thinking about treatment failure. And then a urine culture would be helpful to tailor the antibiotic to that infection. There are, however, situations where getting a urine culture is mandatory, it's kind of indicated. So pre-procedure, pre-urologic procedure, like case 2, pregnancy, like case 4, and renal transplant in the first 30 days, we have the indication of getting a urine culture and treating the bacteria in the urine, even if no symptoms, has shown improved outcomes. Back to you, Yusuf.
Thank you, Noah, for this nuanced discussion. Jumping a little bit ahead to broadening up this case and thinking in general, I want to ask you as like members of the CT Solvers, as members who always join CT Solvers, I'm going to bring up 2 quick cases, and if you can just put in the chat what diagnoses come to mind when I bring up these cases. The first case is a 60-year-old male immigrant from India presenting for shortness of breath. And if you can just put in the chat, what symptoms and diagnosis do you think of? We have in the chat TB, pneumonia. These are good examples. Mucus plugging, TB again. Another question would be, if I present to you a different case, and this case is a 60-year-old male presenting for, with no past medical history, presenting for shortness of breath. What diagnoses do you think of if for in that case, for example? CHF, PE, pneumonia. Yeah, thank you, everyone. And I just want you to see here the trick we played on ourselves. Is that if we framed this patient as a 60-year-old male coming from India, presenting for shortness of breath, we would jump to thinking of organisms like TB. While if we frame this case as a 60-year-old male presenting for dyspnea, and then in the social history review that he's from India, TB might not be in the first 3 diagnoses that we think of, or melioidosis, for example. We would think of prevalence rather than the general framework that this could be like an exotic infection. And the topic I want to discuss briefly today is anchoring bias. Anchoring bias is the tendency to fixate on a diagnosis early in the process, where before the workup has completely been done. And this can happen frequently in the hospital, and especially with transitions of care. And this can happen particularly if you get a UA, and we'll get to that shortly. And one thing is that has been studied in the past is how to fight anchoring bias and how to make physicians work against anchoring bias. Because just like we're human beings and we are prone to these biases, so a lot of researchers have wondered, how can we fight against anchoring bias? The simple act of thinking, what else could this diagnosis be, has actually been proven to broaden the differential. Or if you ask a physician, what likelihood do you think this is TB? Or what likelihood do you think this is pneumonia? Makes them think of other diagnoses that could be at play here. Another way to think of is, what factors or symptoms go against my diagnosis and what factors go for my diagnosis? And this helps go against anchoring bias. Another bias that goes hand in hand with anchoring bias is confirmation bias. In that, confirmation bias is defined when we have the data and then we form a diagnosis, and then anything that comes afterwards from data perspective, we would consider as confirmatory towards our diagnosis. A lot of times in those cases, it goes hand in hand with anchoring bias because we would assume the diagnosis from the start. And then anything that comes in afterwards, we would say, oh, I can see here, this is definitely the diagnosis I thought of. For example, if we thought the diagnosis was TB, and then we saw hemoptysis afterwards, we would affirm to ourselves that this belongs to the diagnosis that I suggested, as opposed to thinking of diagnoses that are different. This has been studied as well. How can we treat this bias, or how can we fight against this bias that goes amongst us all in general? There are studies that show that if we start thinking of likelihood ratios or statistics, this can help. So if we think the percentage of patients that present with dyspnea who have TB are less than 1%, while the proportion who have pneumonia are 30%, we are less likely to anchor to our diagnosis or consider this confirmatory to us. Another thing that can help us as well is consider disaffirming evidence. And if we consider evidence that goes against our diagnosis, that also helps physicians think of other hypotheses that may be at play here. This is a brief intermission in relation to biases before we jump back to our last case for today. I'm going to read the case, and Noah will discuss shortly. So this is a 82-year-old female presenting from a skilled nursing facility for somnolence and decreased PO intake. The vitals are notable for fever, hypotension, and tachycardia. the abdomen is slightly distended. And then we're gonna do a 3-minute breakout room, just in general, regarding your workup, thought process, and what would you want to do for this patient. And this will be just for 2 minutes. Welcome back, everyone.
Welcome back. I hope you guys had a good discussion. We're gonna have one person share their thoughts. Okay, who wants to go?
I can share mine if no one goes for it. Well, this is an elderly woman with vitals concerning for shock, and we were discussing in this case the fevers points probably to septic shock as the most common one, and in this case the fever would go for that, although we have to rule out other causes of shock, distributive and other causes of distributive, but also cardiogenic, hypovolemic, etc. The further workup immediately would be labs with also a blood venous gasometry, and probably blood cultures, urinary cultures, an X-ray for ruling out other causes of shock. But in this case, the distended abdomen points toward an abdominal or urinary cause of shock. So maybe a CT and abdomen CT, and specifically with contrast would probably be needed. If the urine cultures are not positive or something like that. And we have to look for other causes of distended abdomen, for obstruction and intestinal obstruction, and something like that. Maybe an abdomen X-ray could be done before the CT. And how do you want to manage this patient with antibiotics and fluids? But in this case, I think we have to ask for the past medical history and ask if there's any relatives or in the residence, if they know if this patient is would benefit from aggressive or what kind of aggressive treatment, because I don't know the basal situation of this patient. Another test I forgot would be an ultrasound to look for urinary retention, and for try to address more or less the bulimia, the state of the bulimia of the patient.
Yeah, amazing discussion. This is exactly what we were thinking. The diagnosis with this patient, fever and shock, unclear history, we have to have a suspicion for sepsis and treat it as such. So we would start this patient on antibiotics and fluids for the septic shock, and we would send a thorough workup. I love that you guys picked up on the distended abdomen, and we're looking for other causes. As we know, the patients can have as many afflictions as they them well please. So they might have an infection and they might have an intestinal obstruction, and that is amazing. So basic workup was sent, and the first thing back was a point of care UA, revealed pyuria. The reflex culture, it's going to grow E. coli in the next couple of days. The med review, the only really relevant med was hydroxyzine. And a KUB showed dilated bowel loops consistent with stool burden. So we have this septic patient, and now we have a point of care UA showing signs of pyuria. So could this be a urinary tract infection causing sepsis? Could this be urosepsis? Yes, it definitely could be a pyelonephritis causing urosepsis. Is it certain that it is? No, it's not certain. We don't have any really specific signs and symptoms that points towards the urinary tract. And if we say, and if we put in the chart, this patient has probably a UTI causing sepsis, so this patient has probably urosepsis, we can have enormous complications for this patient. And Yusuf is going to talk a little bit more about that right now.
Yeah, jumping to another bias, which is premature closure. Premature closure is when we label the final diagnosis or close in the case too early in the diagnostic process. As exampled here, if we say this is sepsis secondary to UTI, you have a fever, sepsis, you have a positive UA, then we would close off the door for further workup for other sources of infection, of fever, of hypotension, and that would count as premature closure. And one way to counter this as well is to, like I said earlier, to persistently consider other hypotheses. Even if I was documenting this patient in particular, I would say, for example, shock, presumed septic, possible etiologies, and I would write UTI as one of them. And then I would say how I'm going to cover it, but I wouldn't put my big title as sepsis secondary to urinary infection because it's only presumed, and I don't want to have premature closure in this case. Back to you, Noah.
So the patient is septic, we act first and ask questions later to further clarify. So the important thing I want to highlight here is that we need to make sure that we do ask those questions later. So we do have to keep looking for other sources of infections, including lung, GI, skin and soft tissue, and bloodstream infections. Her altered mental status is probably multifactorial. We need to make sure she doesn't have a stroke. We need to make sure that the constipation isn't causing delirium. Looking for urinary retention, as you mentioned. Stop the offending medication, hydroxyzine, in the elderly population is a very deliriogenic medication before attributing this altered mental status to the dirty UA, to the septic picture. So that's what we did. We had watched this presentation, the management VMR, and we knew we had to keep looking. So we went back to the patient, she was doing a little bit better, the vitals were a little bit better, and we did another physical examination. We turned her over, took all her clothes, did a very thorough skin examination, and we saw an oozing sacral ulcers with signs of local inflammation. The blood cultures grew as aureus a couple of days later. So this patient actually had a septic shock secondary to a soft tissue infection. And the UA was just an unrelated finding. That's the end of the second case. The last teaching point we want to cover is management of UTI specifically. So how do we choose our antibiotics? And I thought of bringing the specific antibiotics per the guidelines, per up to date, but those, we can always look it up, and it will depend on the susceptibility profile of where you're practicing medicine. And I really wanted to bring a framework of approaching antibiotics. So antibiotics, they can cause harm, not only with resistance to drugs, but they can also cause harm to the specific patient. Ciprofloxacin, as we mentioned in the first 4 cases, is a very, very bad antibiotic for the patient. It has tons of side effects, and it can cause harm to our patients. So we have to treat the UTI causing the least harm. So we choose the antibiotic with the narrowest profile, so we don't foster resistance, and with the most favorable side effect profile. That's why nitrofurantoin is a very good antibiotic because it concentrates in the urine. It doesn't have a lot of side effects, and most bacteria are very susceptible to it. One thing I would urge you guys to watch out for, and it may be a practice change in the next couple of years, is possibly will not treat simple cystitis in females anymore, in non-pregnant healthy females, because it has been shown that antibiotics in that population is only for symptom management. So we would give antibiotics and the symptoms would go away faster, but it doesn't affect the risk of progression to a more complicated disease. So that may be a practice change in the coming years with some research. And I would also urge you guys to be very cautious with the patients that have high risk of progression. So immunosuppression, men, and patients with anatomical, urologic and abnormalities. Those patients, we have to have a lower treatment threshold, and we have to monitor response to therapy very closely because they can decompensate very fast. And that's all me and Yusuf have for you guys for today. We'll not be closing the session. We'll be staying here, reflecting with you guys if you want to, doing questions and receiving feedback from you guys if you like this format. And we would really like for you guys to hang out with us. If you have to leave, we also want to be mindful of your time. Our hour is up.